Pirkka, can you just confirm you can hear me?
I can hear you.
Oh, great. Hey, Joe. So we stick to the plan for the introduction. You start and then I introduce everyone.
Yes.
In French, huh?
In French. I'll do it in French.
Yeah. So we stick to the plan for the introduction. You start and then I introduce everyone. Looks like we have an echo. In French, huh?
In French. I'll do it in French. Yeah. Does that come from YouTube? Delay.
And then I introduce everyone. Is the sound already working with the people that are connected on the webinar?
Does that come from YouTube?
Is the sound already working with the people that are connected on the webinar?
So, good evening, afternoon, and night, and morning to everyone in the panel and the participants. My name is Pirkka Vikatmaa. I'm a vascular surgeon and represent the European Society for Vascular Surgery, Helsinki University Hospital, and the Finnish Surgical Society. My great privilege is to welcome you all to today's webinar, a continuation of the successful collaboration between the two societies, European Society for Vascular Surgery and the Endovascular Resuscitation and Trauma Management, EVTM. We are lucky to have a worldwide panel of experienced hands-on experts from Tokyo to California. The panelists are chosen not to do mainly their scientific purposes, but because they have practical experience on REBOA covering many different specialties. There may be a bit of a focus towards vascular surgery as this is an ESVS event as well. Our main goal is not to give you answers, but to provoke discussions and distribute knowledge about the possibilities and pitfalls with REBOA. EVTM has been organizing well-visited hands-on workshops since 2014 in Örebro and symposia since 2017 globally. Gradually, this is going more and more global. It is a special honor to chair this webinar with the heart and brain behind EVTM activities, the Israeli-Swedish enthusiast and vascular surgeon Tal Hörer. Welcome, Tal, from Örebro, Sweden, and also with probably the #1 expert on advanced endovascular aortic treatments and the president of the ESVS, Stéphane Nolan, from almost as beautiful and large city as Örebro, Paris, France. Stéphane, I give it over to you to introduce the panelists.
Thank you very much, Pirkka. Thank you, Tal. It's a great honor for the ESVS to be part of this joint symposium with EVTM. I'm very happy to introduce a very unique faculty here. So on the panel, we have from east to west, interventional radiologist Sensei Junichi Matsumaro from Kawasaki, Japan, and Yusuke Matsumura from Chiba University, Japan. And I'm sorry if I don't pronounce perfectly your names. I was going to do that in French, but I'm going to stick to English. Vascular surgeon and rupture EVAR expert Zoran Ranchik joins us from Zurich, Switzerland. Sweden and Örebro is well represented and hosts this event. Tal is joined by Artai Pirusram and David McGreevy, and also from the neighboring capital, Stockholm, head of vascular surgery, Karl Magnus Wahlgren. And then moving on the other side of the Atlantic from Baltimore, Maryland, we have Megan Brenner, a trauma critical care and vascular surgeon this time talking about REBOA in obstetrics. And last but not least, from US military, the expert vascular and trauma surgeon from Fairfield, California, David Grant Medical Center, Joe Dubose, who performed the first ER REBOA placement resulting in a survivor. So thanks everyone for being here. I'm very happy and honored to be part of this program. And Tal, the floor is yours.
Thank you very much. It's a great honor, Stefan Pirka, to be here and to have this cooperation with the great ESVS. We thought about this event to be a great connection with the European Vascular Society, and the aim was with these people to get mostly vascular surgeons and IR people to lead this challenging discussion about the use of aortic balloon REBOA for hemodynamic instability. I would like also to thank the people of the EVTM, to thank the ESVS management for this cooperation, and of course our sponsors, which are Tokai Medical with the rescue balloon and REBOA Medical with their great products that we will show also. We've shown in the intro and we will show again their products. So thank you for this great cooperation. Also, I would like to thank Örebro University Hospital for the great help in helping in doing this event. So this is from my side, Pirka. I just want to also mention that people can come online, chat, and we will try to bring up people. Pirka and Stefan will lead this. Try to bring up people to even speak and be on video online. We will try to do it and we'll see how it will work along the way. Pirka.
Yes, thank you, Tal. About technical details, we have planned to have both the chat and the questions and answers open. So the Örebro team will be following the chat, and then we will have the questions and answers people picked up also to the videos and for live discussion. We are expecting comments from all around the world. At the moment, I can see 174 participants. There are more than 500 registrations so far, so we are expecting more. There are some numbers that we cannot see that are following us on YouTube and other platforms. It's, at least in Finland, it's a very beautiful day, so people are probably in the parks and beaches looking at their iPhones and so forth, and I hope that all the panelists have big enough pictures so that people can look at them. It should be easy to join from any portable device as well. Johan Söderlund is the technical coordinator, and he will put up some polls. Here we can see a map. I don't know what we can see in the map. Now we can see the participants rolling up. So you can see that in I just checked that the time in Sydney is midnight and Tokyo 23, and on the other side it's 7 or 6 even in the morning. So we have the full day covered globally. Johan, there was an idea to put up the first poll question. Is that possible at the moment?
I think he will fix it. It takes some seconds and he will fix it. And if there are any comments, you can chat and we will try to bring it up. So the first poll is up. Pirka?
Yes, so the first poll is up. Just to get started, have you performed REBOA for trauma/non-trauma? Just for the interest. And after we have the results, which I hope will be coming in quite soon, we will have the first presentation. Now, okay, so 79% of the people listening have not actually themselves performed the trauma or non-trauma REBOA. And this is very good and very interesting because we have a wide range of ideas and discussion to go for. And it also seems that we are not the least experienced in the panel, right? Okay, so let's get started. Tal Hörer, you don't need any more introduction than we had already. Tal is going to talk about REBOA as one of the tools in EVTM endovascular resuscitation and trauma management concept. The floor is yours.
Thank you very much. I will wait for the presentation to come up. And again, it's a great honor. And I want to stress again that the whole work about EVTM, REBOA, it's a lot of people involved. Some of them are in this slide. Also, I would add my mentor, the great Thomas Larsson, and other people from around the world doing efforts. So I will just have to decrease this down just technically here. So REBOA is one of the tools of the EVTM concept, and we see EVTM as a paradigm shift in hemodynamic instability and trauma management. Next slide, sorry. We are working on no ego, just good science and cooperation. Next slide. So REBOA is a hot issue in trauma. It's being discussed thoroughly all over the world. It's great debates about REBOA. This is the ABO trauma registry. These are cases, real cases of REBOA in trauma. It's open to join. This is to show how it works, how it looks like. Next slide, please. Next slide. So should REBOA be used in trauma? This is, again, a great debate. And there are some studies about it, and some that claim that there is low evidence at the moment. You can see some of the studies here. Next slide. But this is how it looks in reality. So this is several cases, how it looks like, how we use it in Örebro, Sweden, and in other places. So this is the real life. Next slide. And in the operation room with the introducer in place, with the C-arm, how it can be looked in a real trauma case. Next. And in other cases, with or without the balloon, but balloons are for birthday. It's not all about the balloon. There are many other issues of interest. These are just some of the cases that we deal with, and probably you deal with in your hospitals daily. Next. So the EVTM concept is focusing on using endovascular and hybrid tools for resuscitation and bleeding control that developed the last 20 years. It's a multidisciplinary concept in trauma and non-trauma, with major advances. Due to the major advances, the use of embolization, stent grafts, REBOA, other balloons, and other endo tools, strategies and adjunct techniques, shunts, endo shunts, ECMO, and modern imaging in the form of CTA, ultrasound, angio, etc. Next. The concept has been published in several articles. These articles, papers, this is one example, and you can see also the EVTM textbook by Springer that came out in the last year. Next. So this collection of tools, which also include the balloon, is all about effective teamwork, multidisciplinary approach, vascular access very early in the injured or the hemodynamic unstable patient, CT angio, which should be done very, very quickly in a dedicated protocol, operating on a floating table or angiographic table with a C-arm in a semi-hybrid or hybrid suite, REBOA if needed, and other aspects like permissive hypotension, adjunct technique, hybrid procedures, endo and open technique. The idea is endo can help you avoid opening a new cavity. It does not replace open surgery. Next. So we're talking about the bleeding patient. And of course, we're talking about trauma. These are some examples on the photos there, but we're talking also about vascular emergencies like ruptures, iatrogenic injuries, postpartum bleeding, gastrointestinal bleeding, spontaneous medical bleedings, and non-bleeders, ongoing CPR, bridge to ECMO. And I'm just have a small comment there. Would you do a thoracotomy on a postpartum bleeding? So maybe it's not that dumb to have different endo tools to stop or help you stopping the bleeding. Next slide. The EVTM concept, you can do it in a normal surgical suite or a semi-hybrid suite like in this with a C-arm. Next. Or a hybrid suite, as you see on these photos, or a hybrid ER, as you see on the photo above. This is from Japan with a Gentry CT, hybrid, full equipped hybrid ER. Next. We're talking about vascular access with airways and access simultaneously, as you see in these photos. Next. and different other methods like TEVAR, stent grafts in different location, embolization, as you see in these examples for the bleeding patients. Next. Or in these one, for example, trauma, thoracic injury, profound bleeding, ongoing bleeding, or different other procedures, rupture aneurysm, as seen in these ones with or without the balloons, different methods and adjunct methods. Next. Is there any evidence? Yeah, it's coming more and more evidence, more publications about the use of endovascular and hybrid tools in the bleeding and non-bleeding patients. More to come, it's expanding. Next. And of course, we cannot avoid speaking about the balloon. Next. The balloon is a temporary tool for blood pressure stability, does not stop the bleeding. It's just one of the tools in the concept, as you've seen in this diagram. It's not a solution. It's something to help you win time. Of course, with the advanced technique like partial REBOA, that is very important. Also for non-trauma might be possible. Next. And this has been published also in the JVTM, now in the 8th edition. And we hope we will have more publication coming out from different centers and collaboration. Next. And we hope to meet in Örebro, depends on the COVID-19 situation, but we plan next year to meet here in Örebro, Sweden, for the EVTM symposium. And again, I would like to thank our sponsors, the society, the ESVS Society, Pirkka, Stefan, and our colleagues here in Örebro for the support of this talk about REBOA as part of the EVTM. Thank you. It's a great honor.
Thank you, Tal, for the excellent introduction. We have built the session in such a way that we have 6-minute talks, and then we have around 6 minutes of discussions in between the talks. So there should be no rushing to the next. So if we have questions from the audience or questions from the chat or questions from the panel, you are free to interrupt and free to come in during the pauses. So that's to be encouraged. Before we go over to the next speaker, I would like to ask you, Tal, that when you're talking about a lot of these resources in EVTM management, does it always need to be in a hybrid theater, and do you always need to have a Raptor suite in your hospital, or is it possible to manage all these issues with normal C-arms or less equipment?
Yeah, I think you can do everything wherever you have the right group of people helping you. Some of the procedures we do in the ER, which I mean, for example, the REBOA itself, I think you can do a lot of things in the normal semi-hybrid, in the normal suite. And you don't always have these amazing capacity of a hybrid, fully equipped hybrid solutions. But I think everything is possible to do, even with a C-arm. And I guess that we can take, I would suggest to take Megan, Joe from the USA, if they can comment on this more. They've done quite a lot of Austrian environment procedures. Is it possible, if Joe, Megan can hear us, come up online? Okay, can you take Joe DeBoss online?
Yeah, while waiting for Joe, it may take some seconds. He has actually posted a question to the chat. Tal, how has your practice changed now with some growing evidence and experience with REBOA? Do you utilize intermittent occlusion or partial REBOA?
Thanks. Until we take him up, I would say that we always, I think one of the major advances of REBOA that we always use now with intention for partial or intermittent, which means that you want to decrease the ischemic reperfusion injury, as we know. The problem is more clinically that you don't always know if you have a partial occlusion. And of course, on the hemodynamic unstable patient, it's at times hard to say, but the idea is to minimize the balloon as much possible. Maybe until Joe's come up, Artai, maybe you want to comment something about the use of procedures in hybrid and semi-hybrid. You've been working with C-arms quite a lot. and not only in the hybrid room.
Of course, it's really fast how you adapt yourself to the very nice hybrid suits, but we've done a lot of work with the C-arms.
The sound is very bad.
The sound is bad. Can you? Yeah, now.
Now, do you hear me now? It's better now? Do you hear us?
Yes.
Yeah. So now we've done a lot of work with our ruptured aneurysms with the C-arm. So
with the old C-arm.
Yeah, with the old C-arm, with the hot C-arms that we need to cool them with ice. So a lot of things are possible, but of course, when you have the hybrid suit, that you just adapt yourself to the ones. And if I just do one comment on the last question about the partial or intermittent, actually what you do is that you follow the physiology of the patient. When they come in deep shock, it's obviously very hard to know if you have partial, so you go for full, but then you just adapt yourself after the physiology of the patient. So going partial or intermittent doesn't matter. It's important to follow the physiology of the patient.
Any of the other panelists, if they want to comment, we will see if we can take them up. Joe Dubos, I see Joe there. Can you lift Joe? Joe, can you hear us? We can't hear you. Johan, can you? Now, can I?
What about now?
Yeah, we got you.
Okay, you can hear me now?
Yep.
Yeah, so I think what we've learned from the American experience to some degree is that certainly every trauma system is different. And in most of our trauma environments, we simply don't have a C-arm at the bedside. So we have transitioned to placement utilizing either extra anatomic landmarks or measured distances, much of that literature actually coming from Europe, and placing this in confirming position with a plain film that's taken in the context of initial trauma care. That has been utilized, and in many instances, I can speak to my austere experience in more limited environments in the back of aircraft and those kind of things that you simply you don't have an X-ray capability. So you do have to rely heavily on your anatomic landmarks and your distances to guide placement. And we could talk a little bit about what zones those are, but obviously zones 1 and 3 will be the predominant zones that are utilized in the context of trauma care. So that does appear to be, if you look at the American registry, the aorta registry, and TAL has an excellent registry collecting the European experience. In the American registry, about 50% of our patients don't have any fluoroscopic guided imaging for placement. Some of them don't even have X-ray for imaging. So it's about 40% that don't even have X-ray for imaging. And we utilize external landmarks, typically the sternal notch and the xiphoid, for the PriTime REBOA device, which is, I'm not affiliated with the company, but that's the only one that is wire-free and available in the United States. And that is one that is most commonly employed. I hope that answers the question.
Pirkka, if we can get back to Pirkka.
Yeah,
you can speak, I guess. Yeah.
Yeah. Joe, one further question. There are some reports on looking at the REBOA balloon with ultrasound, both through the abdomen, but of course in the OR through the transesophageal echo. That's easy, but have you utilized that in practice?
Have not utilized that in practice. Some of those studies are interesting. However, when you're trying to do an ultrasound to examine the aorta, and most of our trauma patients unfortunately don't have a prep bowel, and so bowel gas becomes a major issue, as does any other associated. Most of the time we're placing these, they have blood in the abdomen, which further confounds your ability to view. So I think that there have been some very interesting isolated case series of people looking intraoperatively for utilization. I would say those are probably different than most of the patients that come through and get at least a zone 1 aortic balloon. I think there's some challenges there, but the technology is exciting. Echo also typically not at bedside when the patient comes in. So maybe better utilized for those operative placements that are placed in the operative theater, but not as practical for utilization as it currently stands and is configured in the US or elsewhere, as I understand it, to use early, transesophageal echo to assist with placement.
Pirkka?
Thank you for that. I was actually waiting to get connection with Stefan Alon, but his video was not running at the moment. So I'll take over and introduce the next speaker, Carl Magnus Wahlgren, the Chief of Vascular Surgery in Stockholm. And Carl, my longtime friend, is going to talk about vascular access because that's where it all starts.
Thank you so much. Let's see if I can share my slides here. All right, thank you so much, Pirkka and Tal, and great program and a true pleasure to be part of it. As we already heard from Tal, REBOA has been used in a variety of clinical settings, including trauma patients, rapid AAA patients for decades with improvements of hemodynamic parameters. So my focus is going to be the arterial access, which is the first step in performing REBOA. But this can be challenging, especially in patients with profound shock, hypotension, vasospasm, and even in hypoxic patient, it can be difficult to even recognize between a venous and arterial puncture. It's sometimes difficult in older patients with calcifications and tortuosity, obese patients, of course, and a patient with cardiac arrest. So the access can be time consuming. It may delay definitive hemorrhage control. And just looking at the time of femoral access, it takes minutes. And especially in patients with severe hypertension or with cardiac arrest, it takes several minutes. So this can be challenging. And it also is associated with potential complications that we need to be aware of. We can cause ischemia, we can cause injuries to the vessels when we do the access. So how should it be done in a safe, fast, and efficient way? So I think if we look in most case series and opinions, the common femoral artery is with the percutaneous approach is mostly used, and also the use of fluoroscopy. If we just look more technically on the access to the common femoral artery, it can be performed with a percutaneous approach with anatomic landmarks, as Joe described, but it also can be performed with the ultrasound guidance, which is probably recognized as a more safer option, but also surgical cut down. And also sometimes if we already have existing femoral line, we can exchange over guide wire and upgrade to a larger catheter. This is the ultrasound guidance with a micropuncture kit, and that's what we usually use. And this can be upgraded to a 4 or 5 French sheath to secure the arterial access. And if needed, it can be upsized to a larger REBOA compatible sheath. This is what we use sometimes for obstetric cases or for vascular cases, that we start with a smaller 4, 5 French sheath, and then we can upgrade it. At the same time, we can allow for pressure monitoring or, for example, blood samples if needed. The micropuncture catheter can also be used for upgrade to a 7 French sheath if the smaller REBOA catheters are used, and just to avoid time-consuming catheter exchanges. We talked about the imaging, and preferable imaging is useful. If we use a C-arm in the hospital, it of course makes it easier, and it's even better if the patient is in a hybrid suite that allows us to get the access a little bit more easier and follow the wire. This is just example of older patients, especially for vascular emergencies where we have tortuosities. I just advanced the wire myself into the inferior epigastric artery the other day, and so imaging is useful to provide a safe way up for your wire. So who should do it? That's the next question, and of course it depends on the conditions. It can be very diverse. Are you in a civilian or military setting? What kind of resources do you have? Are you in a trauma center with high or low volume? And what kind of trauma system do you have in your country? What specialties are involved in your trauma system? And of course, that depends who's doing this. Of course, factors that are important are the technical skills, training, of course, the frequency and daily volume you're doing vascular access. Do you do endo cases on a daily basis, or are you an anesthesiologist that do arterial access frequently? And what's the availability? Are you available 24/7 or just daytime? We need somebody that can be part of this 24/7, of course, and we need a plan for complications from the vascular access. There was a recent consensus paper by Tal and Joe and some other authors that said that trauma and vascular surgeons are deemed to perform REBOA procedures, but of course it can be safely performed by other clinical specialties such as anesthesiologists, IR physicians, emergency physicians with the appropriate training, of course. But I think it's so important to emphasize that endovascular bleeding control is a multi-specialty effort to provide the best outcome for these very emergent patients. So thank you very much, and a true pleasure to be part of this program, and I'll be more than happy to take on any questions.
Pirkka, may I come with a comment? I guess you can hear me.
Yes, I can hear you. Sorry, I was muted.
First, before we discuss a bit with Kalle, just to say that we can online, people can raise their hand, show interest, and we can try to bring up people live via video. So if someone is interested to take a question up via Zoom, it's possible to do it. Just a question, maybe the other panelists want also to speak about, just about this. I'm interested, Kalle, about the micropuncture. I hate the micropuncture. I don't know why. I want to use the big needles, especially in when the patients are unstable. But maybe if you can explain how you think for others. I think I'm just have a fixed idea with this. Small needles, I can't see really when the blood is coming. Arta is much better than me in this, but in my hands, I don't know.
No, I think I think you're right, but I think we need to when we try to spread this message with the vascular access and REBOA, I think we need to do it in a safe, efficient way, and with the micropuncture kit, I know it's difficult, sometimes really hard to know to differentiate between venous and arterial puncture. But if you use the ultrasound guidance, especially if you are working in a hospital, I think this is the most safe way to do that, especially in young trauma patients, obstetric patients with small vessels. I think it's the safest way to do this. I know it's more difficult, and it's easier with an 8-gauge needle to get the blood back and you see what you're doing. But of course, it depends on the situation and where you are. But I think as a general approach, I would prefer the micropuncture just because of safety reasons and less injury to the artery.
We have some people, okay, thanks, Kalle. We have some people trying to get video online. We will try to lift, Johan, if you can do it, we can lift up live. Johan is trying to do it. Any comments during this time from others about the access and access issues?
Yeah, I would like to comment from here, and also from Japan. We got from Yosuke a comment that here in Japan, most patients are old and atherosclerosis is always a concern. So guide wire is essential in our situation, not to injure the vessels. I think that's what Kalle was also mentioning, that the trauma patients are often younger. The issue about doing the ultrasound guidance, I mean, I've been training a lot of people doing the ultrasound puncture, also not only in the femoral arteries, but also in the venous work. And as a vascular surgeon, you end up doing thousands of punctures, and that kind of becomes your next hand, the ultrasound. But what would you say, Carl, in Sweden or in your experience, how many punctures do you need to practice before you can master that in the austere situation or in the quick situation when the patient comes in?
I think, going back, we just did, 18-gauge needle punctures with anatomic landmarks, and then we evolved. And for the past decade, I think more or less everybody's doing ultrasound puncture. We try to teach our even surgical residents to do to teach the micropuncture technique. But of course, you need to do this more on a regular basis. But I think there's a lot of specialties nowadays. Anesthesiology starts to do central lines with ultrasound instead of doing it, on an anatomic landmarks. But of course, you need to do several punctures to get some kind of experience, and of course to do this on models first, and then maybe together with your senior colleagues. I think you can quite rapidly learn this technique. A lot of surgeons are doing subcutaneous venous ports, and you can learn these techniques by doing that, of course, on the venous side. And we just taught our cardiologists recently, when you do electrical physiology, they do the venous puncture, and they have dropped their arterial iatrogenic injuries by almost zero by doing ultrasound guided micropuncture.
Can I interrupt, Pirkka, before maybe Stefan would want to say something? We brought up Dr. Simon Fire from Israel. Hi, Simon.
Hey, how are you? Great idea. Nice to see you all. I wanted to ask a question.
Shoot.
About training programs in Europe. I would like to know from our fellow colleagues. I'm trying to organize some kind of best workshop to try to get multidisciplinary training for access. So I'd like to hear if you have any ideas or suggestions in setting up some kind of course, or is it something that you do on an individual basis in terms of training?
Someone from the speakers want to answer this?
Well, Tal, your course in Örebro, of course, is a bit of an access course. We don't have structured access courses in Finland. We do that for all the vascular surgeons and the angioradiologists, cardiologists, and so forth. Actually, the cardiologists do, we counted the punctures, so they do less femoral punctures than the angioradiologists and vascular surgeons. The anesthesiologists obviously have their courses, but the ultrasound-guided courses for a nerve blockade and something like that. And then there's courses on venous puncture, but we don't have, at least here, structured. It could be easy to actually make some, maybe that's a good idea to take forward with both the EVTM and ESVS activities.
Any from the other panelists, maybe someone want to comment? Barak, is someone from the join us? Johan, you take him up. Is he up?
Yeah, hi, hello everyone. My name is Dr. Barak Agwa, and I'm a general surgery resident. I'd kind of like to tack on to this question that we're talking about training. So for example, in our system, most trauma activations are run by general surgeons, and the vast majority of general surgeons have little to no vascular surgery experience, since vascular surgery is a well-established independent specialty here. So as part of my residency, for example, I only had an elective rotation. I could have chosen a different rotation in vascular surgery, and many of my colleagues have no vascular experience at all. So when we're discussing introducing vascular access early on in the pathway of the patient, of a trauma patient, how would you suggest introducing this to non-vascular surgeons, and how can we achieve that safely? People who have very little experience doing vascular punctures, etc.
Yeah, an important question, and how to do something safely that you don't do very often. I think we need to generate ideas on that because the time is flying, and I want to introduce David McGreevy from Örebro, Sweden, to talk about use of REBOA in trauma patients, overview, and actually a bit about the science. What do we actually know about it?
Thank you very much, Pirkka. It's a huge honor to be a part of this panel. Just waiting for my slides to come up. I think we have quite a lot of other questions popping up in the chat. Maybe we could take one of those while we're waiting. Okay, sorry, no, here are my slides now. Okay, so yeah, so my name is Dave McGreevy, and I'm a vascular surgery resident here in Örebro, and I'm just going to speak to you a bit about the use of trauma or REBOA in trauma patients and what it is we actually know. So next slide, please. No conflicts of interest. Next slide. So looking at trauma mortality, it's decreased significantly during the last few years. And what that's mainly based on is because of improved pre-hospital care, early resuscitation, and early critical care. However, what we do know is that the majority of patients that do die of trauma are because of exsanguination. Next slide, please. And this is still a major complication. It's a major challenge within trauma surgery, and it can be taken care of both using open surgery, but also using endovascular methods, or the combination of both, which is actually what EVTM stands for. Next slide, please. This is more the traditional way of taking care of non-compressible torsional hemorrhage in severely injured patients, to open up the thorax and cross-clamp the aorta, having quite abysmal survival rates, especially for blunt injuries. Next slide, please. And this is more the way of doing trauma surgery today, to try and combine both open and endovascular methods of surgery. Next slide, please. But this is not anything new. We've been using these endovascular methods, and specifically aortic balloon occlusion, for many years. Next slide, please. And what is actually shown is in ruptured aortic aneurysms, we can see that for the past, it's actually decreased the mortality significantly. Next slide, please. So what it is we actually know? Well, I mean, we know quite a lot about REBOA, but we also are still lacking a lot of knowledge about it. There's a lot of data, mainly animal data, a lot of very good studies that have been done. The data used on human studies are mainly based on registries and case reports and case series, because doing randomized control trials in these patients are very difficult. Next slide, please. But what we do know about using REBOA is it increases the afterload, it maintains cardiac and cerebral perfusion, and it also decreases blood flow distal to the balloon, minimizing blood loss. Next slide, please. So one of the registries that is used is the ABO Trauma Registry that's been going for the past 6 years. It's collected about 260 cases of the use of REBOA within trauma from all around the world. Next slide, please. And it's generated multiple different studies, they're very interesting studies. For example, the one you can see on the right, which is the first one that came from the ABO Trauma Registry by Dr. Sadeghi, which also started introducing different types of occlusions, mainly, for example, partial occlusion. Next slide, please. Partial occlusion is something that's now utilized quite a lot. I think Dr. DeBose is going to be speaking about this a bit more later on. And it's by using, not inflating the balloon completely, but only partially allowing some blood flow past the balloon to allow some perfusion of the organs. Next slide, please. Next slide, please. There's also the aorta registry that Dr. DeBose was also speaking about earlier. One of the first reports that came out from there actually showed no difference in survival rate between REBOA and resuscitative thoracotomy. And now one of the more recent reports from this registry shows that there was a survival benefit with using REBOA compared to resuscitative thoracotomy. Next slide, please. Dr. Brenner, also speaking later today, has shown, together with us in our group, that the use of REBOA in traumatic cardiac arrest can significantly increase the systolic blood pressure and return of spontaneous circulation. And like Kalle was speaking about recently, or just now, he was about that the vascular access in these severely hypertensive patients, even with ongoing CPR, is possible. You can use even blind puncture, as we've been showing, or what we would recommend ultrasound, and it can be done with a very high success rate. Next slide, please. REBOA has also been for many years slightly contraindicated in the use of thoracic trauma and thoracic bleeding. However, two recent reports, one using human data and the other using, and it is an animal study, showed that the use of REBOA in thoracic trauma for even penetrating chest injuries can be safely used, and using zone 1 REBOA does not significantly increase or doesn't decrease mortality or increase mortality or bleeding. Next slide, please. It has also been used in younger patients. This is a case report, but there's only a couple of these published, and there's no large data looking at this. Next slide, please. However, the reports on REBOA are not just positive. There are some reports that also show a negative trend on the use of REBOA. The investigation by Dr. Bilal and his group showed that there was actually an increased mortality with the use of REBOA in these severely injured patients. Next, thank you very much.
Thank you very much, David. I don't know if you can hear me.
We can hear you loud and clear.
Great. This literature overview shows that there's probably a real learning curve with REBOA. And you were quoting Thomas Lodson, a vascular surgeon I worked with in Örebro. And I guess that learning from the endovascular procedures, how to use a stiff wire, a long sheath, maybe all that has an impact on the results. And to come back to the previous question from our young residents, maybe a rotation in vascular surgery should be part of the program of any general surgeon that wants to be involved in trauma surgery.
I mean, if I was going to comment on this, I would absolutely recommend a rotation in vascular surgery. I mean, I think that with using REBOA, as we many times before have said, the rate limiting stat and the most complicated part about using it is actually gaining the vascular access. And one of the ways, I mean, I had the hugely unfortunate to be working with Tal Herr here to learn how to use REBOA. But one of the ways I learned how to perform vascular access was actually doing surgery on varicose veins. To have a lot of patients puncturing veins, which many times is more difficult than puncturing arteries, allowed me to become very comfortable with the use of ultrasound and just my puncture technique. So that would also be something I would highly recommend.
May I ask also, if we ask our American colleagues, if we can take up and open all the panelists, the American colleagues about their experience. They're doing the best course, back to Dr. Fires and Dr. Agwan questions. They're doing the best course, which is endovascular methods in trauma. They're highly trained people exactly in this question, as Stefan Hallon just raised also. So any thoughts from the American side, if here in Europe we should do in another way, training for vascular access, younger or residents?
This is DeBose. I hope everyone can hear me. In the United States, we all have different trauma systems, obviously. In the United States, it is a trauma surgeon who is at bedside and required to be at bedside at our level 1 trauma centers when these patients arrive. Vascular surgeons are often at home on their couch if it's caught at these odd hours of the night. So we, by nature of this arrangement, had to focus on training acute care surgeons. And what we did find, and we continue to reinforce through review of the aorta registry, is that you can, with some degree of training and experience, translate for acute care and general surgeons, trauma surgeons, non-vascular surgeons, the ability to safely cannulate for the common femoral artery and place a device that is designed for their utilization. We're not advocating, I think we had a lot of problems in the days when we had these wire devices and wires would go to random places, and using coda balloons and things that to the interventional radiologist and the vascular surgeon are part of our tools of the trade. But so the modern devices, the PriTime device, the rescue balloon, those are really designed to be a lower tier singular intervention. And I think we're not trying to teach general surgeons and acute care surgeons how to be vascular surgeons. What we're trying to teach them how to do is one, salvage procedure safely. And that constitutes the full spectrum from access to balloon positioning, placement, and infusion. Thereafter, the vascular surgeon partner has time to come to the operative theater and help if there's a complication with the vascular access or other issues. And I think we have shown on the US experience that you can teach general surgeons and general surgery residents. They place general surgery residents and acute care surgery residents place REBOA at shock trauma, and they do so quite effectively. So I think you can do that. That's with supervision. But
can I counter you and ask Dr. Zoran Rancic from our colleague with great experience of vascular access? Zoran, what do you think about vascular access after Kalle's talk and this with non-vascular? Shortly.
Yeah, shortly, we always try to do it in with ultrasound, but if we try once or two times, if it does not work, we are making open access. So that means we are trained through the ultrasound from the elective cases. So that means in elective, we try always, but if it does not work 2-3 times to puncture, then we are making open access. And we are always doing that in a shock room, and we have facilities to make cut down also in these facilities. We have a set for the balloon and for REBOA, and we also have a set to cut down, always with CR.
Okay, Pirkka, back to you maybe.
Yeah, I was just discussing here with Stefan Olon that we are running short of time. Actually, there has been a question in the chat at least about heparinization. At which point should we heparinize the patients?
I can just answer briefly that we usually don't do it when we use REBOA. We're trying to put cell line in the arterial line. We don't dare really. Later on, when we solve the bleeding problem, then we can do it in locally on the arterial line. I don't know if any from the panelists, Kalle, do you have any comment on this or someone else? Just shortly, and then we have to move on.
No, I agree with Kalle is here. No, I agree with you. These patients are very coagulopathic and has this trauma-induced coagulopathy, and sometimes they have head injuries, and we don't dare to give any heparin. And now with the modern devices, it's smaller catheters, so I don't think there is a need for the acute phase.
Back to Pirkka.
Okay, there's the clock. Maybe I should share my presentation and go on with the program. I thought I'm sharing it at the moment. Let's see. Okay, I'm not allowed to share my screen. Johan, can you help me on that one?
Johan, you need to help. Johan need to help. During this time, I will just say we have some colleagues raising their hands. We will try to get up first the talk by Pirkka, and then we will get people online. Please.
Okay, now you can see it, right?
Yeah.
Okay, so let's move on. We are going to discuss a lot about the small details in practical tips and tricks during this session. So I actually took a bit of a bird's view on this and talking about pre-planning and training on pre-hospital, in-hospital, in the OR, elsewhere in the hospital, and then included some details. So this is my environment, the southern Finland. The blue circle there is Helsinki, which is a centralized system university hospital. We have 3 other centers around performing vascular surgery, but they don't have hybrid suites or very experienced 24/7 on calls. Joe mentioned that there's the vascular surgeon is on the couch. We actually have 3 vascular surgeons on call, 1 in hospital and 2 outside. One is dedicated 24/7 to doing endovascular procedures, but he's at home with a computer and half an hour raisement. But the patients come from far away. And therefore I took up this case from a recent case, a 26-year-old sporty young male with a left iliac mycotic aneurysm repair 1 year prior, bad infection with his own femoral vein. 1 year later, 140 kilometers away, he felt dizzy at home, drove with his wife to the hospital and collapsed in the lobby. I was on call and received a call from a friend of mine, a cardiologist from Helsinki. He was doing his on call out there. And I knew immediately what was wrong because I recognized the name of the patient. And I recommended him to put in a sheet as a cardiologist from the opposite groin for transportation. And the answer was that in this small hospital, I don't have any equipment for sheets. I don't know about that. but the patient came on ambulance, and obviously, as I'm giving the talk, he collapsed under transport and was put on a automatic CPR machine, taken into the hybrid OR directly with the CPR ongoing. And Maarit Venermo, our professor, and myself, two quite experienced vascular surgeons, we were trying to put in an access. First of all, 26-year-old guy with no pressure and spastic, huge amounts of adrenaline in him. It was very difficult to puncture. Also, the CPR machine was giving a lot of movement. So we started a cut down, and my nerve went off and did an emergency laparotomy, clamped his aorta too late, and the patient died on table. The learning points from here are that the referring hospitals would probably have skills, as we have been discussing today, with anesthesiology and cardiology, but they may not have the equipment. So we should distribute that there, because putting in the sheet early is the key. Training everybody is impossible. So I think we should also use the existing skills. And once the sheet is in, it's easy to put in the balloon, even in the ambulance, if you have the system going on. The small detail we learned in Helsinki was that we stop nowadays the CPR machine for puncture. Training in hospital, in our unit, we have obviously, as many of you, the trauma team training simulations. Within that simulation, we have a dedicated REBOA team with one that is actually picked up from the vascular surgeons, because there's a surgeon on call, and one nurse helping him, so dedicating only to this is, I think, is the same as in Örebro. What we have quite good experience about is training for rupture EVAR simulation. We identified a lot of people in order to get a 24/7 service for rupture EVAR. We identified all these scrub nurses, anesthesia nurses, vascular surgeons, anesthesiologists, and radiographers to be introduced into the team, and therefore we started a simulation that's ongoing every second Monday in the real hybrid theater. The results have been published by a friend of mine, Pekka Aho, and in the middle you see the main result, that the true rupture EVARs, 18 of them, had 65 minutes introductory time before, and the needle to access time was 16 minutes afterwards. So the main task was to put in the balloon. The REVAR for aneurysm, or the balloon for the aneurysm, is a bit different. Nowadays, we always start with the balloon, even if we do an open one. We do a longitudinal ultrasound guided puncture because of the calcified femorals. We navigate with the fluoroscopy to the tortuous and calcified iliacs. Often the guide wire rolls in the aneurysm, but actually with a good catheter, it's not so difficult to reach the thoracic aorta, and we always aim for the landing zone 1. One point about the stiff wire and introducing the sheet while the patients are on local anesthesia is the pain that should be discussed with the anesthesiologists. The balloons can actually flip over if you use a loose balloon, and we have gradually gone to the Gore molding balloon at the moment, mainly because it hosts a 10 French long sheet for support. And if you put in a short 16 to 18 French, you can also have the pigtail in the same big catheter from the side. And big ones, of course, because of the EVAR procedure. One more detail is that the closure devices can actually be used afterwards with ultrasound guidance. You need to compress with the longitudinal ultrasound, you need to compress the big hole, and preferably have 2 experienced hand pairs to do it. And this is especially non-IFU, so the companies will not be happy that I mentioned the names. These issues of the trauma patients will be discussed a lot, so I don't go in detail, but just if you look at this CT scan from on Tuesday or on Monday, I think, on Monday, we had this patient with a stab wound, and this is a true CT scan from this 29-year-old guy. So it's a totally different ball game, and you can go blindly in these straight arteries. Maybe to remember about the 20 to 25 centimeter from groin to bifurcation for iliac bleeders. One specific.
We have to continue to the next to the discussion, if it's okay.
Okay. If I may give you this one last detail, is the frozen abdomen. If you have I've experienced this twice. A patient ruptures in the ICU. This guy drawn on the right-hand side was a liver transplantation patient, his third one, and it was a total bleeding from the aorta because of the rupture of the proximal anastomosis. And putting in a first one did not make it possible to enforce the anastomosis. The second one did. So using two balloons blindly in OR may be a life-saving procedure as well. So I'll stop the presentation here.
Thank you very much for your talk. Let's do something, Pirkka. This was a great talk. Let's go to some of the participants, if it's okay. I see our colleague from Spain online. Hi.
Hi, how are you, Tal? Great. Well, first of all, I want to thank you for this opportunity. It's a great thing to see you and to see all the rest of the colleagues down in Sweden. Speaking about educational programs, recently we had the opportunity, as you know, to go to Chile. And also since last year, we're trying to put forward that type of program here in Spain, in Zaragoza. As you know, we're really young with this. I think this online opportunities are going to help us a lot. But one comment that since COVID really stopped our program, what we're trying to put together is multidisciplinary teams with a lot of labs and specialized training for not only for surgeons, but surgeons, vascular surgeons, and also in Spain, intensivists. So I think this copying your model, like in Örebro, it was a great experience in January. I hope to have you guys come over and give us a hand, but I think that's the way to go. A lot of training, hands-on workshops with multidisciplinary teams and organizing that type of activity.
Thank you very much. Great comment. And if I would say in every hospital, there are experts in this and that can help the local people in all of these aspects. Let's go on. Thank you very much. Jan, let's go on. We had some more people. Can you take up online? And we will see how we can continue. Any comments from the panelists until Johan comes up? Johan, you have to open all the panelists and see if you can bring up the next colleague.
Tal, I have a question, if you hear me. It's Stefan.
Yes, Stefan, please.
When I see those balloons in the aorta, my big fear is that they don't stay in position, they move. Is it of paramount importance to use a long sheath to stabilize those balloons?
That's a great comment. I was taught, as you know, of Dr. Larsson, and we always claim that you need the big sheets to hold it. But later on, I think Artai will agree, in our clinical experience, we didn't see this. We saw it more in the ruptures, and in trauma and the others, non-trauma, I don't experience that the balloon migration is a huge issue. It happens, but it's not huge, maybe because they are sort of in such a low pressure at this stage. We do partial REBOA very early. We had one balloon that went up and down, like did a circle, as you remember, Artai. But in general, I don't think there is big issues with it. Artai, do you have any comment on this?
I think there are two issues. Do you hear me?
Speak louder.
Yeah. There are two issues to concern. The first thing is that the most of the trauma patients are the young patients. They don't have any large aortas. And the second thing is that we try to go as partial as soon as possible. So, and the other issue is that the modern low-profile catheters, they are stiffer than the ones that we are Boston Scientific or CODA, which are much softer in the shaft. So we believe that they perform much better in the trauma patients. So I agree with Tal that the issue of migration we had in the older aneurysm patients is not that present with the trauma patients.
I have to comment also, one of the product, I know that we're using all available balloons in the market, and REBOA Medical has a long sheet of 23 centimeter. We use it several times. Maybe it should have, I don't have a better answer than this at the moment. Anyone from the panelists before Pirkka, you take over?
We could continue, Tal, with the presentation of Joe DeBose, because it actually addresses the same problem. And I agree with you that trauma and aneurysms are different. We have actually had a migration of the stiff sheet in a big aneurysm. So if you have a 12 centimeter aneurysm, then it doesn't always help, even if you have the sheet. But in trauma patients, obviously, there is no aneurysm to protrude to. But next, Joe DeBoss has been already talking. So Joe, can you share your screen and give your thoughts about practical issues in trauma REBOA placement?
Yep, trying to share my screen here.
Until Joe succeed with the screen share, just a comment. This is also an issue with getting up the balloon at the first point with the ruptures. Attempts in the ER to do this are usually not so successful. So as we know as vascular surgeon, the aneurysm prevent you just to put in the balloon very easy up. It's a big issue that is not the issue in the trauma or other non-trauma, non-aneurysmatic patients.
Can you see my screen now, Tal? Okay, thank you, Tal. Can everyone hear me okay?
Yeah.
Great,
yeah.
Fantastic. So thanks again. This is an outstanding opportunity to interact, and I do appreciate everybody for allowing me to participate. So I was asked to talk about briefly in 6 minutes about the practical aspects. There are elements of each of the steps of REBOA that have practical applications for trauma. Underlying theme here is you must continue resuscitation throughout as you deal with these trauma-specific, and I'm speaking to trauma here, trauma-specific elements. And I don't have time to go through all of these, but I will touch a base on a few of them. One of my esteemed colleagues already talked about the common femoral artery access. This is really paramount to success. In the trauma setting, we've had some changes in philosophy about the early utilization of continuous arterial pressure monitoring as opposed to waiting for a blood pressure cuff to go off every 6 minutes. This does afford us the opportunity to get more information about the physiologically depleted trauma patient earlier. It's technically much easier to do early than late. And it doesn't mean that you're going to do REBOA, but if you have the common femoral artery access and you do it appropriately, it makes life much easier if it is needed. We all know there's a majority of the people on the audience today are vascular surgeons or interventionalists, but these are things I have to explain to the trauma surgeons, who are the majority of people in the US that place these devices, the importance of placing the device in the common femoral artery and avoiding these known complications. I do advocate strongly for ultrasound access, as I think most of us would. This is not, this does require some skill acquisition and training, but with more aggressive utilization of early monitoring lines, the skill set can be increased in terms of its acquisition. Okay, of course, occasionally some of these times it's not open, not available, right? You don't have the ultrasound. There are other challenges in the trauma patient. If they have active CPR ongoing, I do not advocate for ultrasound guided access. I think it's a foolish endeavor and that we should proceed with open access. However, the open access is not looped control of each of the branch vessels. It is literally cutting down through the skin and subcutaneous tissues until you can see the anterior aspect of the common femoral artery. So the anatomic landmarks are important to know, the incision size, but this is also a skill set that does require some development. We utilize at Shock Trauma, and I think most of the places in the United States, the micropuncture device. I am a big fan of micropuncture. I think the more that you use it, the more you become facile with it. And I think it's a fantastic initial access. We now upsize to a 7 French sheath for subsequent placement. And these are all part of our kits. And many of the institutions that have talked about utilizing this have talked about a systems-based approach or a practice-based. You have to rehearse this. You have to use the same devices every time, particularly when you're using non-vascular surgeons. They don't need 20 options for sheaths. They need 1 in the kit. So you need to plan accordingly. We use the ER REBOA catheter device. This does resist migration a bit more because as opposed to having a wire, it's now a nitinol infused spine. So if you're able to put your hands on this, it has some significant rigidity, which allows you to reduce the degree of migration. And it has an A-line port above the balloon, which becomes important if you're going to transition to partial occlusion. This is our protocol for the University of Maryland Shock Trauma. It's one that I actively circulate to most people. Zone 1 occlusion for hemorrhage sources that are unknown or positive fast exams. In Zone 3, if you can confirm that it is in the pelvis and the patient remains unresponsive to initial resuscitation, emphasizing that the majority of patients will respond to resuscitation and will not need a REBOA by the time you get the early monitoring in place. The duration of, there's been a lot of questions and continue to be questions about how long the balloon can be up in the trauma setting. The general kind of consensus that we have utilized in the US with our consensus statements is 30 minutes in Zone 1 and 60 minutes in Zone 3 before reperfusion becomes such a burden that survivability is just going to be called too much into question to really validate continued utilization. But there are a lot of factors, however, that do affect that. That's with total occlusion. I am an advocate for early partial REBOA, and these are the kind of the rationales for that. But without going, just to simplify this a bit, really what we're trying to do here is to use the balloon to establish normal tension for the heart and brain, which have the lowest thresholds for ischemia, and maintain a hypotensive resuscitative state below the balloon. So some perfusion is allowed, but not so much to disrupt clot or mitigate more advanced bleeding within the abdomen or in the lower sources. You have to, if you're going to use partial REBOA, which I think is probably the next frontier that we should. I've been using this for about 5 years and I've been very pleased with the results. It has to be premeditated. It has to be rehearsed. This is not something you can be the only person at the table understanding what people are doing with partial REBOA. It does require 2 A-line setups. You can see in the screen there, you can see the A-line above and below the balloon. But that closer to a happy blood pressure is what the brain and the heart are seeing, and that below is what the organs below are seeing. I typically utilize the sheath from the ER PriTime device for my blood pressure above, or if they have obtained radial line, that works nicely. And then the side port of the 7 French sheath to titrate these different pressures. So it requires a dedicated team. It requires a clear understanding of everything that everyone is doing in the room. It starts with the initial 10 minutes of occlusion. This is not a scientific hard stop time, but rather a rough estimate of how long it's going to take you to get adequate resuscitation on board before you can start coming down on the balloon. And there are a lot of practical recommendations for what you can do at that time that I list here, mainly getting access and starting resuscitation and finding where the source of bleeding is. It does take micro adjustments when you are titrating the partial REBOA, and in all honesty, it takes a team-based approach because you do need someone who is primarily dedicated to the balloon, and the balloon control can be very dynamic, even with small adjustments. That includes up, down, back to full occlusion. Sometimes it can be very rocky, and that person must be trained appropriately and really not distracted with other requirements. I can't take out a spleen and run partial REBOA, but I can have my fellow take out the spleen or my fellow do the partial REBOA while I take out the spleen. That is demanding, however. Once you get hemorrhage control, now you can start the weaning process. With partial REBOA, you've already started that and you've mitigated some of the risk for reperfusion, but we need to now focus on maintaining adequate resuscitation as we wean the balloon completely. That includes calcium, I would say is becoming a very important adjunct that we're appreciating with early utilization of REBOA. And I would encourage everyone to be very aggressive with their calcium utilization up front. In most animal models that undergo complete occlusion, if you do not utilize supplemental calcium early, the animal model will result in mortality. And I have found that to be likewise true in humans. As far as other adjuncts, bicarbonate drips, all the vascular surgeons in the room will be familiar with at least some of the, if you want to call it voodoo, or some of it's better studied than others, but in terms of resuscitation adjuncts that we utilize, those need to be considered for employed. I do take out the sheath. Yep, I do take out the sheath in the operative theater. There's really no reason to include it beyond the operative theater. This mitigates all the risks of thromboembolic complications. Get your arterial monitoring somewhere else. The complications are known and they fall into several categories that can be educated and rehearsed. And this is where REBOA, I think, fits in. It fits in, but in those patients who have not been resuscitated, who have not responded to resuscitation, but prior to the kind of Hail Mary type approaches that we have typically reserved for resuscitative thoracotomy. And there are a lot of unanswered questions. What are partial responders? What are the key elements of resuscitation? What are the timeframes we can utilize? And all these continue to be studied and need to be studied. So with that, I will close, and hopefully I met Tal's time constraints here.
Thank
Almost.
you.
Thank you very much for your talk.
Excellent talk. Excellent talk. Thank you very much. We are a bit
sorry,
short
Pirkka.
of time. Tal, do you have a burning question in the in Örebro, or should we continue? I actually have one small detailed question to Joe's presentation. When you say that you are looking at the pressure downstream from the same sheet as you are looking as you are introducing the REBOA through, we have some experience that is actually not the true pressure downstream. So if you put a sheet on the other side, there will be a difference. Do you think that it can be used in a 7 French sheet with, for example, PriTime REBOA?
In my experience, it can with the 7 French sheath, and I agree with you that it's not going to be perhaps a precise measurement of all the arterial pressures in the arterial tree distal to the injury, but it is a singular measurement that you can use for titration of partial REBOA. So if you have time to get access on the other side, that is fantastic. If all you have is the side port sheet, that is at least usable data that you can utilize to titrate those pressures. Most important for me is the pressure above the balloon, maintaining adequate perfusion of the brain and the heart. Whatever I get below the balloon is a free lunch, so to speak. Ideally, you'd like to.
May I comment, Joe? I think we're trying to do double access always. Sometimes we don't succeed. Maybe we should hear a comment from Japan, from Dr. Junichi or Yusuke. They are online. If you can bring them up, if we can hear some comments about their use. They've been using the rescue balloon for many years now in Japan. Any comments on this, on partial issues, how to use?
Yes. Yeah. First of all, I do agree to get two access, bilateral access, and the other side can be used for the distal measurement or distal pressure measurement. And if we use the side part of the sheath, probably Joe, do you use 7 French for prime time? Okay, probably for rescue balloon we should use 8 French, but 8 French is very good to use. The waveform is not so sharp, but the mean arterial pressure is almost same in our swine experiment. And when it comes to the partial REBOA, the distal pressure is a key to the titration for the partial REBOA. So I do agree to measure the distal pressure. But I have the question for all panelists. Do you measure the distal pressure routinely for the REBOA patient?
Yes.
Oh, okay, good.
Yes, also here. I just have one comment on this. I stopped using 7 French. I'm using 8 French whenever possible. I want to get the pressure curve there if possible. I think it's not a big deal on all existing balloons. I think the main issue is to get something. And then I just have to disagree with Dr. Boss about the definition of partial. If we have, I think we agree here in Örebro, I don't know the others, but if we have a possibility to take up the balloon partially from the beginning, when the patient has 60 in pressure and we can raise him to 80, we don't really know if it's partial. I would agree what Joe would say about it, but if we can raise him to 80, we will not raise him to 100. So we will wait to the anesthesiology to catch up and we will do other things. The balloon is just a bridge, but the idea, as I see, a major thing is not to just blow the balloon up, take it up to maximum. The idea is to take it up very slowly and see what's the reaction, if there is a reaction. I don't know if the panelists agree with me.
I personally agree with you, Tal. I don't think there's a magic number above the balloon, but if you have in your mind that you are optimizing perfusion of the brain and the heart while still maintaining some distal perfusion, whatever numbers you use, we don't have the research to tell us what the magic number is yet. But if you're utilizing that in your heart and your mind, then you're going to be in a good place, I think.
Okay, any other comments? And of course, you can raise your hands on Zoom.
Well, I would interrupt this discussion because it's going to continue with Zoran's presentations on rupture aneurysms as well. But we need to move on to Megan, who's going to talk. Megan Brenner is going to REBOA in postpartum hemorrhage.
Thanks, Tal and ESVS. Can everyone hear me? My slides are hopefully coming up.
Hear you loud and clear. Is it coming up now? Johan is taking up your slides, or she is running it? She's running it, okay. We can't hear Megan. Can you hear us?
Everyone see the slides?
Yeah.
Perfect.
Yeah, you're on and we see the slides.
Okay, great. All right, thank you. Great to see everybody. Just a few minutes about REBOA for postpartum hemorrhage. As we all know, about 3 to 5% of deliveries involve postpartum hemorrhage and 12% of pregnancy-related deaths. That's just data from the US. The American College of OBGYN ACOG definition of postpartum hemorrhage is greater than 1 liter of blood loss or blood loss associated with signs or symptoms of hypovolemia. In my limited experience of clinical use of REBOA for postpartum hemorrhage, it occurs in 3 different clinical scenarios. The first one, the emergent intra-op consult from the L&D suite. So these are patients that end up in L&D and in a crash C-section. Maybe the placenta previa or accreta has not been diagnosed previously, and it's clearly an emergent intra-op consult for hemorrhage. Second scenario is the pre-planned C-section, where the diagnosis of placenta previa or accreta has already been acknowledged and accepted, and this is obviously a much more calm situation to have REBOA occur. And then much less commonly, but I have seen it occur, is postpartum hemorrhage in the ED or the ICU, where the hysterectomy has been performed, the patient comes to, or the C-section or hysterectomy have been both performed, and the patient comes to the ICU and ends up having postpartum hemorrhage in that setting as well. So as we all know, certainly everyone in this Zoom meeting knows REBOA for postpartum hemorrhage is not new. If you go into PubMed, many case reports where balloon aortic occlusion or iliac occlusion has been used for prophylaxis and emergent hemorrhage control in these situations. Most of the publications have been about bilateral internal iliac artery balloons, mostly for prophylaxis. That has not become the standard of care over the past several decades. It is certainly used in some institutions for this purpose, but is certainly not widespread standard of care. We don't have the exact reasons specifically, but one may be, maybe source control, as we know from the anatomy, and I'll talk about it in a second. There may be different, collaterals that come off higher, especially the middle sacral or higher in the aorta, and the balloon really needs to go into the aorta rather than the internal iliac arteries. Another issue which we have run across, of course, in trauma is the availability for urgent hemorrhage control by consultants. That may be another reason why that has not been adopted as standard of care. As I mentioned with the anatomy for zone 3 REBOA, we place it between the lowest renal and the aortic bifurcation. The anatomy of the gravid uterus, obviously those huge collaterals that form off of the iliacs. Sometimes there's the middle sacral. Sometimes the arteries can come off as high as the top of zone 3. So really zone 3 occlusion is ideal in patients that are hypotensive. But just like we recommend in trauma for profound circulatory collapse, if the patient is near arrest or in arrest, then place the REBOA at zone 1. Regardless, they need resuscitation with aortic occlusion, secondarily for hemorrhage control, but don't hesitate to put that balloon up higher if the postpartum hemorrhage is causing a significant and profound circulatory collapse. So looking at the literature just quickly, as I mentioned, the prophylactic balloon occlusion of the internal iliac arteries has kind of been the most studied and reported experience with postpartum hemorrhage. As I read through this briefly, they're basically just descriptive case reports and studies. They quote about a 5% thromboembolic event rate for this procedure. Again, this is prophylactic. This is not an emergent setting. But as I read the conclusion, I kind of laughed because it's the same conclusion that we still honestly write and read in the REBOA literature. Larger studies and randomized controlled trials are essential in order to determine the safety and efficacy. So I think we're all still struggling with this for both trauma as well as, of course, postpartum hemorrhage as where this is going. Our colleagues in Norway put together a really nice series of 36 patients. As we see in trauma, the systolic blood pressure increased nicely, no deaths, few thrombotic complications, and one non-fatal aortic complication. Our colleagues in Cali, Colombia put together a systematic review, many patients looking at the prophylactic use, less blood loss, and fewer blood products were transfused. This is just an example of how we do it at my institution when patients are scheduled for planned C-section. We do this in the operating room for a multitude of different reasons. We have the NICU team available. I place the A-line, use a micropuncture. I'm on totally with Joe with that, the easiest thing to do. Place it, it's part of the prep, connect it, and then the C-section occurs, and obviously no time to take pictures while there's a REBOA occurring, but this is just what the gravid uterus looks like with the placenta adherent. Just incredible amounts of blood loss. So the other second issue we have is obviously the emergent consultation in L&D. We have called, we've put together a multidisciplinary team, and we call it this CODE-OB MTP, multidisciplinary response. The trauma team comes in, we place the A-line plus minus the REBOA. This is a multidisciplinary issue and teamwork with anesthesia, blood bank, and then the post-op ICU treatment and management by the trauma team and surgical intensive. So essentially the recommendations I have from our brief experience is creating a multidisciplinary protocol, known high risk, scheduling in the OR is so much easier than doing it in the L&D if you can, common femoral A-line placement and high risk C-sections, certainly PrEP, ultrasound guided micropuncture and femoral A-line. It's obviously almost impossible to place this in lithotomy positions. The patient needs to keep their groin access extended. The patient needs to be supine. OB often does a cysto after the C-section. Please just remember not to let them yank the leg up in lithotomy. Keep one down, they can still perform it. Zone 3 is sufficient for many patients, but zone 1 is maximum hemodynamic support. Vigilance is always with the pulse exam, low thresholds for angiograms and duplexes. The coagulopathy of pregnancy is incredibly different than trauma. We have seen and anecdotally heard so many more rates of thrombotic events. Pregnancy is real. It makes REBOA a much higher risk. So I would recommend placing the A-line early, but only upsizing to that large sheath when aortic occlusion is required. And so far with our experience, much, much higher incidence of thrombotic events than in trauma. Thank you.
Thank you,
Thank
Megan.
you for a great talk.
Excellent presentation and a lot of details. And to the audience who were not able to follow these fast presentations with a lot of technical small tips, the presentations will be on YouTube afterwards, and we will inform on that.
Pika, we have some comments, I think, from Cali. There is a group there, Colombia. We will check if we can bring them up with some significant postpartum hemorrhage. There are very few groups in the world that are doing it often, and it would be nice to hear after Megan's presentation. I just want to comment on this very briefly. Yesterday, we were called in for a case after 2.5 liters of blood loss. We are very careful with this procedure in young women. Of course, we don't want to do it. It's as a life-saving. Megan, do you agree with this?
Oh, I believe that it's absolutely just as in trauma, absolutely life-saving. The main difference is that we really have to remember this higher rate of thrombotic events. Maybe we're just having it in particular. We haven't really flushed out why it's happening, but it really is a risk-benefit issue. Again, the thrombotic events are real. They're significantly higher. So there needs to be a clear discussion with not just with the patient, but with the OB team, saying do we really need to do this, and understanding the potential consequences, and also again not letting that 7 French sheath sit in, or letting the catheter just sit there and maybe needing the balloon. Again, I would just advocate waiting until you need the REBOA to upsize to that 7 French sheath and to perform aortic occlusion specifically, just to reduce the risk until we can figure out how we can mitigate that in these patients.
Okay, Pirkka and Stefan, back to you.
Yeah, Megan, there are 2 questions. One question from the chat is that how do you manage with heparin there? And I have another question. In my hospital, we still do selective cannulation of the both common iliacs in these placenta percreta cases that are estimated to bleed a lot. Do you think it's too much of a fuss, or should we just go to a simple REBOA?
So I'm completely biased. I'm always going to say just go to the simple REBOA. It starts with an A-line. It's something that the in-house trauma surgeon, if they are comfortable with REBOA, can do. It's only 1 puncture site instead of 2 bilateral sites. Again, I can't emphasize the thromboembolic events. 2 punctures is just doubling the risk of complications. So I would advocate simply for the REBOA. As I mentioned before, placing it higher in zone 3, there's probably a lot of collaterals, and I think there's hemorrhage that is occurring from those higher branches and higher collaterals. So I think REBOA just hits hits it right on the spot, rather than bilateral iliac artery occlusion. Heparin I would not use in these patients, but again, using a TEM or Roteg to try and understand the coagulopathy. Certainly not while the patient's bleeding, but maybe through the sheath as a running through with saline. Perhaps after the hemorrhage has stopped, will reduce the complications again, but just heparin is largely not advocated in, obviously, the hemorrhaging patient.
Thank you very much, Megan, for sharing your experience with us. Time is flying, so I think we need to switch to the next talk and ask Zoran to talk about the use of REBOA in ruptured AAA. Zoran, you're live.
Till Zoran comes up, we bring it up. And until this, I just want to comment until Johan brings up Zoran Rancic. Just one comment. We've been speaking many years with Megan, with Dr. Fox in Texas about this jaw intervention study. The PPH, postpartum bleeding, is the leading cause of death in women in the third world. This would be an amazing tool if done correctly. If we will have people of this community, there are around 300 people online now. If we can find the right place in a secured way to do this as intervention study to save women's life. I think this is the platform to do it in the correct way. Zoran.
Yeah, hello everybody. It is a great privilege to be among all of you in the panel and among 300 participants watching this Zoom. So I send the slides and waiting for the slides. So I will try to show you results from our University Hospital Zurich and from our Clinic for Vascular Surgery. And I hope that we will see the slides because before the next one, and the next one. So that means in 1952, DeBoss did the first open surgery, and then 1994, Frank with the first endovascular treatment for rupture AAA. Next, in the patient who was, the next slide, please. In a patient who was not capable for the open surgery. Next slide, we started in the University Hospital to do endovascular procedures in 1998. And since then, next slide, we did in 21 years, 300, almost 400 patients out of them with a mortality rate of 70%. What is important during this time, we identified which are the key elements for treating the patient with the rupture. This is the hemodynamic imaging, procedure, abdominal compartment syndrome, and TIM. Next slide, please. And all the patients with aortic emergency undergo the same path, and this path is very good standardized. They are coming to the shock room, they are getting the CT to prove the feasibility, and then during the anesthesiologist is doing their own workup, we are deciding are we are going to the open surgery or EVAR. And then next slide. Then the hemodynamic is a part with all these aortic pathway. Next slide. So the standard operating procedure for every, next slide, the standard operating procedure for every patient coming to the shock room or before entering the hospital, that means after the first telephone call, is to lower the blood pressure. So this is the beginning of the hemodynamic stabilization of the patients. Next slide. So the basic principle of hypotensive hemostasis, permissive hypovolemia, and controlled hypotension are the part of this hemodynamic stabilization. The next slide. If the patient has a high blood pressure, we are actively lowering blood pressure. Next slide. Also part of hemodynamic stabilization in patient with rupture is local anesthesia. So we are trying to do it whenever possible in the local anesthesia. And finally, next slide. In case of hemodynamic crash, it's coming REBOA, endoclamping. And in general, this is not something new. In 1953, they used for the control in the gastrointestinal hemorrhage. In 1977, next slide, they put it for the first case in the rupture case. We did it and published that in 2002. Next slide. What is interesting with this REBOA is the phase that we have very fast stabilization of the patient. So this stabilization is really fast, and you can see this how within 2 minutes we have increase of the systolic blood pressure of 35 to 29. Next slide. But what is important to know, we have to play with 2 balloons if we are using that in the rupture treating by endovascular means. So that means the first balloon is going above the celiac trunk, the second balloon is then going within the aorta. And what is important, we can put the balloon transfemoral or we can put balloon transaxial, and we have to know how to do this. We heard a lot about this from Carl, arterial access. We are always going over the stiff wire, and we are always using the long sheet 12 or 12 or 14 French sheet, 45 centimeters, and Stefan mentioned. And placement of optical group, we are using always the compliant balloon, and we inflate that to profile of aorta. The next slide. Very briefly, going to this procedure, that means we are going from one side, putting a sheet, then we are inflating a compliant balloon. Next slide. Next slide.
Out of slides. Zoran, maybe this was the last slide we have anyway.
Okay, then it's then I will continue with my slides. Sorry. So that means I will try to summarize what you don't see. That means whenever we are using a balloon, we are going from one side with a balloon. Then we are inflating a balloon above in the zone 2 or trying to do it in the zone 1. Thereafter, we are deploying the stent graft and then making angiography through the sheath. Thereafter, when we are removing the balloon from that means we have to use 2 balloons for this. Maybe it's important to realize whenever this balloon to use, it's not easy to use, and we have to learn how to do this. Now I'm going through my slide and say what we have to be aware of. What we have to be aware that vascular access, as we thought, it can be percutaneous and open surgical. We have to be aware then where will wire end up. That means we have to have CT thoracoabdominal to see if we are going from below or from above for putting a balloon. There, sometimes if we are going transaxillary clamping from the patients with pararenal aortic aneurysm, then we could not go for the complex endovascular procedures. Maybe it's better to go for the fast track open surgery. There is a complication, and we are going to hear that in the next talk. And what is also important, we are organizing some workshops, management for aortic rupture, when we are teaching the participants. This is under auspice of ESVS. We are organizing that in a flow model, so all people can learn how it works in a flow model to put a balloon and Ypsilon, a stent graft, and how is that working in a virtual model. And what is also important, use of endoclamping is not sole activity. This is the endoclamping is a teamwork and might be trained. And this is what we are doing in the mock hybrid room. The two last slide is the question, is that REBOA in rupture AAA literature? The Christos Kartokos made one meta-analysis in 2015 when he said the utilization rate is 14% and of REBOA in patients with rupture. And there is identified lower mortality in studies with a higher rate of use of aortic balloon. Also, for the first time, ESVS guidelines from 2019 implementing use of REBOA, and there is a recommendation 68. Aortic balloon occlusion for proximal control should be considered in hemodynamically unstable ruptured abdominal aortic aneurysm. Patients undergo either open or endovascular repair. So with the excuse that we didn't see all the slides, I'm happy to answer on your questions. Thank you very much.
It was a great talk. Thank you. I just want to go directly to Stefan Alon, which is one of the most competent people about a very complex aneurysms. Stefan, what do you think about this when you imagine your horrible cases that you deal with, very, very complex aorta? This with dealing with the access itself, how we should think in the bleeding patient, especially these ruptured aneurysms that are not so easy. Do you have any tips or thoughts about these issues, the complex cases?
I think Zoran was crystal clear on something that we routinely do is to get support from a long sheath to secure the sheath in position. We even suture the sheath to the patient's skin to make sure that it doesn't move throughout the procedure. What I was going to ask Zoran is, would you consider, because when I see your algorithm, it seems that the REBOA was used only for endo. Do you consider it also for open? Do you do open and endo in the same room? Is it a hybrid room where you do both? Because I think that it makes sense in those modern hybrid rooms to position the REBOA using imaging and all your tools, and then switch to open if you need to.
Thank you, Stefan, for your question. And this is exactly what about this balloon and sheet. We have never forget this. If we in the trauma patients, we don't have experience, but in aneurysmatic patients, if we don't support the balloon with the sheet, this is always disaster. So that means this is one must. The second point, where we are putting a balloon in the shock room when the patient is deteriorating, that means hemodynamic instability. That means we are putting a balloon and then we are checking, are we going to do open surgery or endovascular surgery? That means with the balloon, patient is going to the hybrid room. In the hybrid room, if we see if it's possible to do endovascular, to do it open. So that means if we are going that endovascular, this is okay. This is the complex way how we are going to use this, both balloon, but if we're doing open surgery, that means the balloon is there to stabilize that. That means, answer on your question, yes, we're using balloon to stabilize the patients in open surgery, but also in endovascular.
Great, Zoran. And we have a question from our friend Alexei Svetlikov from St. Petersburg. We've seen that you've really improved your results now that you're using the balloon routinely for those ruptures. What is the next step? How can you improve even more your results?
I don't know how can we improve our results. I think the results are, it's really difficult. We could not do a magic in total. Maybe the problem is with we improved, we are using in 70% the balloon, and maybe this is for some people too much, but this is because we want to stabilize the patient. Maybe we can, we're using a lot of parallel grafts. We started to use also fenestrating grafts for the rupture. Maybe if we combine and we add additional fenestrating branch of maybe T branch in the rupture, maybe we can do this. But now we are, I think if we follow the algorithm, then probably this is the best result. The better results I could not imagine. How can we do this? Maybe if we have to make before the operation rehearsal, this is what was done with Gent and Isabel van Herzele. We did a lot rehearsal in the elective patients, so we did also rehearsal in the rupture cases. Maybe pre-operatively to rehearse the procedure and see how to make it in the easiest way. Probably that could be one way to improve results.
Zoran, I have a question from Helsinki. We use also a lot, and we always initiate our rupture cases with putting in the balloon. But the question that we're discussing a lot is that when should we stop having the REBOA? I mean, it is a compromise when you move the REBOA into the main body of the when you deploy the main body, you move the REBOA under the renals. If you keep it open during the fishing of the contralateral limb, you will probably have a little bit more of abdominal compartment syndrome postoperatively because the hematoma is getting bigger and bigger. So how do you tackle that problem in Zurich? When do you stop using the REBOA once the patient is stable?
Yeah, thank you, Pirkka, for your question. Exactly, this is the point. We are playing with these two balloons till we exclude the aneurysm. That means we have this balloon in the main body of the Epsilon graft. Then we are going to deflate the balloon and cannulate contralateral gate and then deploy the stent graft with inflating balloon. That means finally, when we are sure that we excluded the aneurysm and the end of the limbs of the prosthesis is within the common or external iliac artery, then we are going to remove balloons. We know that we have compartment syndrome as a complication, but we are opening abdomen relatively liberally. So that means this is the big difference between REBOA and our clinic, because we are doing this decompression abdomen.
We became more liberal after your talks there.
That's good.
If I can just add here, I think we have one of these poll questions. Maybe we can ask the audience regarding this issue. I think Johan can raise the question. Let's see what everyone listening thinks.
And Pirkka can lead this, maybe.
Yeah, so the question is, do you think REBOA should be part of rupture aneurysm treatment? Yes, if EVAR is planned, yes, start even open rupture as they do in Zurich and Helsinki. I don't know where REBOA actually. No, you can do without it, and I don't do rupture EVARs, rupture aneurysms at all. So we give the audience a couple of seconds of answering. The next speaker should be ready in a minute or so because he comes from Örebro, Artai Pirosram. Yes, we have the answer. Yes, start all the procedures with the REBOA balloon. So we have a quite strong opinion towards that. Artai, please.
Thank you very much. It's a great opportunity to share the experiences that we have here. and I hope that my slides are coming up. Yes, there you go. So next, please. I have no disclosures on this one. Next, please. So we've heard already that the REBOA can be used in different environments and in different patient groups, depending on what kind of resources that you have in place. Actually, there's a potential for using REBOA in all the environments and all the patients that are bleeding. Next, please. So REBOA seems to be quite straightforward. You need to have basic skills in Seldinger technique. You need to have a catheter balloon, preferably the low profile, and you can choose your patient group, which is the non-compressible torso hemorrhage patients, trauma or non-trauma. And together with some promising data, then you might think that it's just straightforward to go ahead and use REBOA. Next, please. But let me start with the data, and all this promising data that is published and we hear about it, they come from the centers with high level of clinical experiences. So people are using these procedures. They're quite experienced using the REBOA. Next, please. And actually, to this date, there is no solid evidence that REBOA is superior to any other methods that can help you get temporary hemorrhage control. Next, please. So in my opinion, the REBOA is only one tool in a system of care. So the whole system consists of the acute care unit that you do damage control resuscitation. Then you have your definitive hemorrhage control unit. It could be operation theater, hybrid suite, angio suite, or whatever which is in your facility. And of course, when you take the patient afterwards in the ICU on a post-op. Next, please. So any attempt to implement REBOA without establishing the whole chain of care might just lead to increasing the complications rates and might give you some headache. Next, please. So there are some potential problems with the REBOA. It could be concerned with the group of patients that you choose to treat. It could be procedure or post-procedure related. Next, please. So starting with the selection of the patients, patients with non-compressible torso hemorrhage are believed to have some benefits of using REBOA, but there is lack of evidence and lack of experience in some group of patients. For example, the patients with massive intrathoracic injuries, like intrathoracic aortic injuries, major pulmonary vessel injuries, or cardiac tamponade. And in fact, some of these patients might harm from using the REBOA. From the aorta study, we've learned that they are presenting some good numbers with the patients with a traumatic brain injury, but of course there is some more research to be done in order to understand if the patients might harm or benefit from the REBOA. And of course, we've heard about the geriatric patients with the tortuous anatomies, and this could be a challenge if you want to do a REBOA procedure blindly. And we know very little about the children. I know that Tal has done REBOA on one child with good results, but we know very little about it actually. Next slide, please. So if we go ahead with the procedure-related potential problems with the REBOA, most of them are within the axis. Now, we've heard about previous lectures about the problems with getting inside the femoral artery when the patient is in the hemorrhagic shock, and you know that there is a potential that you harm the vessel with arterial disruption, thrombosis, dissections, and these things might lead to distal limb ischemia or even distal limb loss. Next, please. And you know that's why you need to have a protocol that I'm not going to do to the details, but it's very important that you know who is getting the access and how early the access should be done. Next, please. And as soon as the balloon is inflated, the clock is ticking, and you need to be aware of the ischemic insult to the torso organs, to the spinal cord, and of course the perfusion injuries. There are some reports about the overinflating injuries to the arterial or even aortic ruptures. Next, please. So even afterwards, you need to be aware to monitor the patients for the reperfusion insult, and we know that the renal and pulmonary dysfunctions are among the most common things that we encounter in the ICU. Next, please. So in summary, I think that the REBOA fits in within the system of care that requires the 24/7 multidisciplinary resources. You need to pick up your patients with right protocol, and you need to know when and how early you should put your REBOA in, and you need to have an active and time-sensitive decision-making in order to minimize the time of occlusion in order to take the patients to the definitive care. Next, please. And I think that you need to have a system to identify the patients that are in risk of immediate, early, and delayed complications of the REBOA. And I think that all the centers that are using REBOA need to have a protocol for data collection in order to get better evidence. Thank you very much.
Thank you, Artai, for bringing us on the table with some complications as well. It's always important to remember that once you're using a technique, you have complications out of it. Do we have burning questions from the other panelists?
I have a burning question for Artai. One of the complications that I fear is a rupture of the aorta by inflating the balloon. How do you consider the size of the aorta on the pre-op CT? Do you measure it, and do you adapt the volume you fill in the balloon regarding that diameter? How do you do that?
That's a very good question, because the trauma patients are in deep shock, and you can actually not rely on the measurements that you do on the CT, and the tactile feeling that you have on the balloon is not correct. So I honestly follow the physiology of the patients with the pressure above and pressure below, and that might be a better idea, just not to, because as soon as you have the pressure above to an acceptable level, then you know that the balloon is in a good position, it's inflated with the right volume. So you cannot go by the milliliters or the volume of the balloon.
Continuing on the same question, Artai, what do you think about compliance of the balloon? Is it a good or bad thing?
I think in my hands, I cannot rely on that. I think that the most important thing is that to follow the physiology of the patient. That is the thing that I rely on most.
So you use a compliant balloon or a non-compliant balloon?
We use always the balloons that we are using, the old ones, with the Koto or the new ones. They are semi-compliant as well. I mean, they are not total compliant or non-compliant. So I think the issue is not about the compliance of the balloon. The issue is about the physiology of the patient.
Pressure, yeah, okay. There was a very interesting or very important discussion regarding the aneurysms and the continuous bleeding after rupture aneurysms. If there's a big hole in the aneurysm sac and an endo leak, how should that be addressed in the acute situation? I mean, if you open the abdomen, it will still continue bleeding. What would you do?
I think that is anyone who is going to answer, or?
Artai, go ahead. Sorry.
So it's in. I mean, if we do endovascular, you can have a type 2 endo leak. But if you want to go open procedure, I think you can deal it in different ways. But the open repair should be of course the method of choice if you are in the open abdomen.
No, I mean that if you do an endovascular procedure and you have a type 2 endo leak that bleeds into the free abdomen through the hole, what will you do then?
In our experience, type 2 endo leak doesn't deteriorate the circulation of the patients if you're doing endovascular repair. I mean, I don't remember any case that we have done any kind of active embolization of the lumbar arteries.
No, we don't either do it, but if the patient has a full open rupture and then type 2 endoleak is sufficient to have a back bleeding towards that and it bleeds into the hematoma, then we sometimes have to open the retroperitoneum and then we actually suture the sac instead of opening the sac and suturing the lumbals.
Yeah, that I don't have any experience on. Zoran, do you have any comment?
Yeah, I want to comment on this. In that case, when we open this and we see the bleeding, and it is endoleak type 2 through the internal iliac artery, and we have a hole. So what we are doing, we are not trying to make a direct suture of this. We are taking a xenopericardial patch, and then we are closing this hole with a patch, with a small bites, let's say 1 centimeter far away from the hole, and then trying to close this. And this is working in many situations. So that means not conversion, then just to put a xenopericardial patch where it's the hole on to close this.
Yeah, so in our experience, what we try to do, if it's a type 2, not a 1 or 3, is we try to wait 2 or 3 days for the patient to stabilize before we bring him back to the OR with a proper CT prior to opening him to fix the issue. But obviously this is not an option if the patient has a type 1 or 3 endoleak.
I agree with you, but I think the problem is we have abdominal compartment syndrome, and when we have to open abdomen, and then when we see the active bleeding, in that case that means we have to do something. In that case, we are putting a patch.
And the patch you use because to enforce the suture. So why do you put the patch? Why don't you just close the sac?
Yeah, if you try this, it's because this is the weakest part of the aorta or the weakest part of the artery, and it's very difficult to suture this. It's very, the sutures are, it's not holding at all.
So felt would be the similar. I mean, I have personal experience of 2 or 3 cases. So we did something and it held, but felt I think was used in one of them. So it's not the pericardium, it's something to support it.
Yeah, something like this.
May I just come in with this and continue on this with the complication? I think Artai touched some very important points about the complications and REBOA, and we know that many of the older cases, when we didn't use partial REBOA, no teams around, you don't think about abdominal compartment syndrome or access problems. I think this is a major issue that we know better today. I'm interested to hear the panelists if someone has comments on this, the complications and the fears of REBOA and when never to do it. Please feel free, open your mics and if you want to comment.
Hi, I'm Jim from Japan.
The question was too difficult.
Is it Jim from Japan trying to speak?
Yep. We have in the past very early days when we started to use the balloon, several ER emergency physicians make very bad complication, that is aortic, not rupture, aortic penetration with the balloon catheter, because they don't know, they are not skilled enough, but they want to do that, and they did that. So at that time, we do not have a good training program. So without training program, we could have that kind of complication with like aortic penetration or aortic rupture complications. So training, I think is important.
Okay. During this time, I thought about we will take the great people and companies that are helping us. We like to show their products. So we have some seconds. Johan, if you can take up the loop We can continue the discussion, but both REBOA Medical was very generous to help us. They're using a balloon that is limited in the diameter and is built originally for a postpartum bleeding, and come back to what you comment. So it cannot go to more diameter than it's built for, and might be used maybe in this reason cannot rupture the aorta. And the other great company is Tokai from Japan, with their vast experience with the REBOA, with the rescue balloon that we can follow here, their products. And I would like to thank them again for their support for this webinar in cooperation with the ESVS and the EVTM. Just more about complications. I'm very interested to hear from Dr. Dubos. You're with us. If you can demute your microphone. Dr. Dubos, you're in the States now. There is a growing experience. Do you have a bit the feeling of did we learn a lot? We should have done it differently?
Yeah, Tal, I think obviously understanding what the complications can be and where the risks can be mitigated is key. I think we all kind of work together, many of the people on the panel looking at that from trauma perspective. I think that, and then incorporating those learning points into our subsequent training with the BEST course really did have a significant impact. From a personal perspective, it seemed like, in the US is different, right? Because the majority of the people employing it actively here are actually trauma surgeons, and they really took up the banner of this as a potential tool for examination. And most of the complications that occurred early that seemed to garner the most visibility were actually had little to do with the REBOA per se, so much as sheath mismanagement, which are things that all the vascular and interventional surgeons on the line and being involved today understand very well. But a typical trauma surgeon who's not had to manage an existing sheath in the ICU or worry about the complications of downstream issues was important. And the trauma context is different as well, because as opposed to a vascular, a lot of the questions about heparinization, systemic anticoagulation is a common tool of the vascular surgeon. In the trauma realm, you're typically going the other direction. You're giving FFP, you're giving platelets, you're giving tranexamic acid, really fighting to combat a coagulopathy. So how do you balance the risk of the distal thromboembolic complications in the setting of giving things that are going to cause thromboembolic complications? And I think the real answer from what I try to
shortly, if you can.
Yep, is remove the sheath.
Remove the sheath. Okay, Pirkka, we're going to you now.
Yeah, I think we will have to continue with Japan. We have two great speakers from Japan, and they're sharing a very short presentation. I've seen some slides, and I fear that it is a bit longish to the 6 minutes. Please, Junichi Matsumoto and Yosuke Matsumara, shoot.
Hi, good afternoon. I'm Jun from Japan, and I'm a radiologist belonging to the emergency department in the university hospital. And Yosuke is an intensivist and also covers emergency IR in Chiba Emergency Medical Center. 10 years ago, we were together in the same hospital, and he was a trainee in the radiology department. Since then, we have been collaborating a long time, and now he is my boss in research. As we discussed today, REBOA is a double-edged sword. It elevates proximal blood pressure. At the same time, it causes distal ischemia. To evaluate the change in circulation and to evaluate the change in circulation and perfusion under REBOA setting, we conducted swine experiments. Yosuke, could you start your presentation?
Yeah, thank you, John. I'm Yosuke Matsumura from Chiba, Japan. And here's our today's key message. The first, the monitor the distal pressure. We reported the result of our research last year. Distal pressure monitoring and titration with the present balloon volume. So we used a rescue balloon in this experiment. The balloon form changed like this, but is it true in the aorta? Actually, no. The balloon form changed like this from cone to spindle shape. So, by the way, what is total REBOA? When you feel the tactile feedback, but it is too subjective. Usually it is overinflation. And when the balloon diameter reaches aortic diameter, but you cannot see the balloon like this. So we defined the total REBOA as the cessation of the femoral pulse pressure, and balloon volume was recorded. This is the pressure curve. So as you can see, the proximal pressure plateaued after 6%. But at that time, you still see some positive flow. So this means 6% is enough inflation to elevate the proximal pressure, and it also allows the distal perfusion. But the pressure is not equal to the perfusion. So we want to speculate the organ perfusion. So we visualize the perfusion of the vessel and organs with dynamic 4D CT scan and reported this result just recently. We scan the peak continuously for 2 minutes and analyze the CT data at the portal vein and liver parenchyma and SMV. And this is a movie of the 4D CT perfusion during the partial REBOA. 0, 20, 40, 60, 80, 100%. So let's take a look at in detail. So you can see the portal vein here, the SMV here. Portal vein is a surrogate for the liver, and SMV is for bowel perfusion. So this is the time density curve. X-axis is the time, and Y-axis is the density. And we use the area under the curve as the surrogate parameter of the bowel, the organ perfusion. At the portal vein, the AUC becomes smaller and smaller in high degree occlusion. And the same trend was seen in the liver parenchyma as well, and also SMV as well. So area under the time density curve in the liver and the bowel decreased linearly according to the percent balloon volume. So you can speculate the organ perfusion with percent balloon volume. And thirdly, you should understand the venous system. This is the same movie. Now you can see the retrograde flow in the IVC. You see the significant congestion in the venous system. So in normal setting, IVC flow comes from the foot side, but in the REBOA setting, IVC flow comes from the head side with severe congestion. So to evaluate the blood flow, my colleague Dr. Izawa conducted the swine experiment using phase contrast MRI. So we evaluate the venous flow. And as you can imagine, mean arterial pressure and CVP increased in the REBOA setting, but pressure is not equal to the flow. So when you look at the blood flow in the IVC decreased significantly. It is blocked by the afterload. And interestingly, blood flow in the SVC increased approximately 3 times higher than usual. So this is the dynamic 4D CT scan of the neck. So now you're watching the significant congestion of the jugular vein. So this means this may explain overperfusion of the brain or interruption of the venous return in the REBOA setting. So let me wrap up my talk today. The monitor the distal pressure and define the total REBOA with balloon volume, and titrate partial REBOA and speculate the organ perfusion. And the CVP increase, IVC flow decrease, and SVC flow increase. So you should be careful about the venous hemorrhage in the liver. And you should be careful about the ICP elevation during the REBOA. Thank you for your attention.
Pirkka?
Thank you, Yusuke. Thank you for the science brought in this time by the radiologist. That's not very common, actually, at least here in the Nordic countries. Great to hear. And speaking about science, we all know that the Tal Hörer's initiative, the journal should have more and more papers. So once you do your science, please send them in to Tal. We have still a couple of poll questions. That was the last talk we had. And then we have about 10 minutes to go to wrap up this session. So I would suggest that you in Örebro pick up the most burning questions. And if there are some directed to Yusuke and to Japan, I would be happy to hear them.
Okay, let's do like this. If someone in the audience wants to, you can raise your hand and then we will send a click to you that we can take you online. Only if you're interested, raise your hand on this, on the Zoom. And we will also take up and poll, we are preparing for it. I would just say one thing in summation, we heard a lot about this REBOA issue, but I think we have to stress that it's a balloon, and Artai spoke a bit about it, and I think Zoran and all of us agree that it has to go in a system, in a system that is safe. I think all of us would agree, and I'm sure also the ESVS as a vascular society should recommend, of course, the safe use of every instrument, and of course this one. If someone has anything to add about this issue, about the safe use from the panelist, please.
So let me comment on the safety use. So I would recommend to measure distal pressure, as I mentioned, because we can define the total REBOA. So we can avoid the overall inflation and we can titrate the partial occlusion. So for this reason, I would recommend to measure the distal pressure and measure the balloon volume for the titration.
Okay. We do also always ultrasound clinical examination after every access, of course, in trauma, and of course in REBOA. Joe, do you have any comments on this? Joe recommend also completion angio before, when you finish a procedure, a trauma procedure, which is of course different from others. Any comments?
I do attempt to do a brief angiogram, at least through the sheath, to ensure that there's no thromboembolic events distally that I need to deal with immediately. It just takes a few seconds in our configuration, a simple C-arm and a handful of 10 cc injection of contrast to determine if you need to cut down and deal with that, or if you can remove the sheath or use a percutaneous closure device.
Okay. I would add also a point. We did several weeks ago, a patient, he was with no pressure, blunt. He was with no pressure here in the ER, and we put the REBOA in, and I tried to advance in the iliac and felt a bit resistance. And thank God I stopped there. And of course, as we suspect, he had a significant injury to the aorta, and we didn't push in the REBOA. And I think this was a very good thing to learn also. Don't push it, never push it. I think we have Professor Kessel online with us. Let's take him up.
Hi, good evening. First of all, thank you for a beautiful web seminar, organizers, speakers. I am, how my old friend Joe says, I am typical trauma surgeon. So my question is very simple. I look for Joe's protocol for REBOA using in Baltimore trauma shock, and the first road cross-section is portable chest X-ray. So if you have some suspicion for aortic injury, you don't use the aortic balloon. Is it the usual practice for everybody? All us know that the sensitivity is very, very low. And my second question is, when you decide to remove the sheath, I agree with you as soon as possible. Yeah, but what the people were thinking about?
Okay, Joe, do you want to take it?
Yeah, I balance the simple considerations. Early sheath removal complications will be pseudoaneurysm, expanding hematoma. Pseudoaneurysm is very rarely an emergency that needs to be dealt with emergently, whereas limb ischemia is an emergency that has a time limit in a matter of hours on it. So I balance those two considerations. If I take the sheath out and I get some small number of pseudoaneurysms of the groin that I need to deal with later, I balance that versus against the risk for ischemic limb in the setting somebody's getting TXA, FFP, and all those kind of things. That's how I approach it from trauma.
Can I just ask you there, Joe? I mean, if you have a patient that, for example, you place the balloon, the patient becomes stable, you can take the balloon down and remove it. When you say you want to remove the sheath as soon as possible, I mean, if the surgery is still ongoing, will you remove this sheath before the surgery is done, or will you leave it in place because the patient might become unstable later on?
If you're using it for monitoring purposes, I think you're better off getting a radial line or a smaller diameter monitoring line in the contralateral groin. You just mitigate those risks for the thromboembolic complications with even at 7/8 French sheath. Remember the trauma population, I'm giving active TXA, active FFP. It's completely different from a risk perspective than the vascular setting, in my opinion.
But if you might have to use the balloon again, will you then have to re-puncture? Would you rather do that?
Yeah, your point is well taken. If they're still in a rocky phase where you think they might need a balloon, but I would argue that those patients that are still in that rocky phase need to stay in the operating room and continue resuscitation to make sure that you don't need to do additional operative interventions. So
let me break in. I'm sorry. Thank you very much. And it was a great point. Pirkka, we go to you now for the final word, and Stefan alone to finalize this meeting, if it's okay with you.
It's totally okay. Are we so out of time so we don't take the polls anymore?
I think we should summarize now. Johan, okay. How are we on the time? I think we have to...
Stefan actually sent me a message that he went to help a fellow in the OR, and he wanted to give his warmest gratitude for all the speakers and all the participants. We have had a lot of participants all around the world, and we have had a great talk. We had great discussions. We were in the panel, we were having this discussion on whether we have enough time for discussions or not, and we still didn't. So Tal, you were right. The discussion would have been ongoing forever and ever, which is very good because there are no clear solutions and answers. There's only a lot of questions around the REBOA to be developed. We have some people who are in the middle of the night already at 2 o'clock, some people who are at 1 o'clock, and some who are going to spend the day in the OR after this. I thank you all for staying up on these odd hours. On the behalf of ESVS, I thank you, Tal, and your team about the great collaboration we've had some time, and make the opportunity to invite you all to ESVS month. As you know, due to the situation, we don't have an on-site meeting this year in Krakow, but we will have an online event in late September.
We will take up the slides now, Pirkka, from the end slides. Pirkka, thank you very much. Do you want to mention anything more before I take over?
It's okay. We will actually have planned to continue this collaboration during the European Society month with an EVTM workshop at least.
And we, on the EVTM side, I just want to thank very much the ESVS. It's a great collaboration, no ego, just good science and collaboration. I want to thank also the people of the EVTM locally and all over the world. People are doing amazing effort to do things to save life and contribute in new ways, which is quite amazing. I want to thank the panelists from all over the world for helping us and being with us, giving the talks. I want to ask also to thank the sponsoring companies with their great products and their help. Without them, it's impossible to do it. I would like also to thank our media company here, Johan and the guys here, and of course our colleagues here, David, McGreevy, and Arte Pirosram, and most of all, Stefan Halun and Pirkka. Thank you very much. It was great to work with you. We'd like to thank everybody joining us to this ESVS and EVTM broadcast. And we are finaling it. Thank you very much and take care. Goodbye.
Bye-bye.
Bye.